Good afternoon, everyone, and welcome to today's webinar, Transplant Outreach, Two-Center Strategies. We're glad that all of you could join us, and we have a terrific presentation planned for you today. My name is Corey Bryant, and I'm the Communications Manager for the Alliance. We have just a few housekeeping items to go over before we begin today's program. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner. So if you have any questions that come up during the webinar, feel free to submit them at any time, and once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. We are recording this webinar, so we will not be opening the phone lines. That means for all questions, they must be submitted electronically using this chat feature. Registration is currently open for our upcoming Get Connected webinar entitled Donor Family Services. It's more than just a memory box, and this details some inventive approaches to family aftercare. So be sure to join us for that on March 13th at 2 p.m. Eastern Time. Registration is also open for our next transplant webinar entitled Frailty Assessment, a crucial component of the kidney transplant candidate evaluation. That's coming your way on March 27th at 3 p.m. Eastern. So you can register for all of these webinars and more on our website at organdonationalliance.org. Now for today's webinar, we are offering 1 CEPC credit and 1 nursing contact hour, courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim continuing education credits. And if you're listening in a group, and we know that many of you often do, please make sure to get the evaluation email from your group lead. And it's a very brief online evaluation which will allow you to receive your credit. Now, as a reminder, for nursing, you'll have 14 days to claim your CEs, and for CEPCs, you will have 30 calendar days. All right, at this point, I would like to introduce our moderator, Melinda Fox. Melinda is the Transplant Administrator for the University of Kentucky Medical Center and a member of the 2018 Alliance webinar faculty. Melinda, we're glad to have you with us, and at this point, I will turn it over to you to introduce our presenters.
Thanks, Corey, and good afternoon, everyone. It's my pleasure today to introduce 2 knowledgeable speakers with diverse and valuable experiences to share with us. Our first speaker is Helen Costis. She's the Operations Director at Michigan Medicine's Transplant Center. She completed her Master's of Health Services Administration 20 years ago, and since then has held clinical operations management positions in several organizations. She spent the last 12 years in management at Michigan Medicine, with the last 5.5 years in transplantation. Our second speaker is Jennifer Milton. She serves as the Executive Director and Clinical Assistant Professor at the University Transplant Center, a partnership between the University of Texas Health Science Center at San Antonio and University Health System. Jennifer was introduced to the field of transplantation 25 years ago and is now responsible for 6 organ failure and 5 transplantation programs. She also serves on several local and national boards, including her current role as the Vice Chair of the UNOS Policy Oversight Committee and Vice Chair-elect of Donate Life America. So we're going to kick things off with Helen.
Thank you, Melinda. Can everyone hear me okay? And thank you, everyone, for listening in today. In our Transplant Center here at Michigan Medicine, we have placed quite a large focus in recent years on referring physician outreach. Each year, our outreach manager, Stacy Brand, meets with our various program directors throughout the center to outline our different strategies for the year. This helps us to gain buy-in from our programs. Many of our outreach efforts have helped to better develop relationships with these referring physician groups identified as a result of these strategic plans. As a result of meetings with these referring groups, we recently learned that some of our referring groups felt that we weren't really doing a great job of returning some of our patients back to them, and they kind of felt like once their patients came here to us for transplantation, that they would never come back to them. And so in order to address these concerns, we formed a 6-month kidney refer back committee to document which of these patients have been referred back, and for those that were not, the reason why. This has allowed us to explain to the referring physicians the reasons their patients have not yet returned to them, which has increased their satisfaction. Another result of our strategic focus on outreach has been to partner with our hospital physician liaisons We have invited them to our outreach meetings and vice versa and have been able to share best practices. After our patients are transplanted, we send our 6-month refer-back staff to the patient's second post-op visit in order to educate the patient about the 6-month refer-back plan and to also take their pictures at this visit. We then send a picture of the patient to the referring physician and also to their dialysis center. We've received pretty positive feedback from the staff of the dialysis centers about receiving a picture of their transplanted patients. And lastly, each of our referring physician groups receives a New Year's card. Our outreach manager also coordinates the CME activities for our center. Each year we host multiple CME programs in the communities where our recent hospital mergers and acquisitions have taken place, and also in other strategic communities of focus. We also hold a monthly transplant conference where CMEs for staff and physicians can be attained. And we've also partnered with the Department of Internal Medicine here at the hospital to help us with CME needs such as online registrations. Our center has also placed quite a large focus on dialysis outreach over the last several years. We have partnered with Explore Transplant to provide education for our kidney patients, families, donors, and dialysis staff. We've held 11 sessions so far that have included many dialysis nurses, social workers, and techs. We've also partnered with Explore Transplant on their Explore Living donation initiatives, which have allowed us to provide additional education to patients, their families, and donors. As part of these efforts, we have created the Facts and Myths of Living donation program for all of our patients in the community. A few years back, we also decided to fund half of a social work FTE to visit dialysis centers across the state to provide education, answer questions that dialysis center staff may have, and act as a liaison with the outreach manager between our transplant center and the various dialysis centers. Our outreach manager also oversees quarterly status reports that are sent to the dialysis units regarding listing status of their patients, and these are sent out by an outreach clerical assistant. Our outreach manager and outreach social worker also hold approximately 2 transplant expos per month. What they do is visit dialysis centers with our peer mentors and provide staff and patient education. We've also invited the dialysis staff to visit our adult abdominal clinic here at the hospital for a day-long educational event. The dialysis staff has told us that this day has been extremely beneficial to them. Then they are able to actually tour the clinic and see firsthand what it's like for the patients who are going through the journey of transplantation and what that looks like in the eyes of the patient. 2 years ago, we also developed a newsletter that we sent to the dialysis centers and have over 400 recipients on this mailing list so far. And we worked really hard to develop and maintain the relationships with these dialysis centers. Our outreach staff also manage our marketing and education materials, such as our patient education books and all of our brochures. We've recently condensed the full English version of our patient education binder, which is really long, that we give out the day of evaluation, and condensed it in order to translate those into both Spanish and Arabic. Our outreach manager has done a phenomenal job growing our peer mentor program over the last several years. We have so far recruited and trained more than 80 peer mentors across all of our Oregon programs, and we utilize them in our patient education classes. They've gone on dialysis center visits, pre and post office visits with the patients, as well as visiting with the patients while they're inpatient. Every year, we also hold an annual peer mentor celebration, or luncheon, to celebrate and thank our peer mentors, which is very much appreciated by them and gives them all an opportunity to meet with each other and network. Our hospital has also partnered with the Institute for Patient and Family Centered Care to develop training for all of our peer mentors. And our outreach manager has also developed a Kidney Quarterly peer mentor newsletter to keep all of our mentors informed of the program and upcoming events. Our centers also put quite a large focus on developing partnerships with other organizations and our local communities. Our partnership with the NKF has allowed us to hold the PATH program, which is a self-management education program for patients, and it's also given us an opportunity to participate in walks and other events and partner with other organizations and statewide educational symposiums. We've also partnered with the Michigan Organ Tissue and transplant education program in order to educate on issues facing minority populations. Finally, we've been involved with various events for the World Kidney Day. We've held quite a few hospital health fairs and symposiums, and have also presented quite a few posters at various conferences. This slide is just to give you some examples of ongoing outreach programs and upcoming outreach programs that we have. We began a program called the Facts and Myths of Living Donation, which I briefly mentioned earlier, and that educates patients on the facts and myths of living donation. This has been expanded to a statewide program now where we send a team consisting of our outreach staff, physicians, living donor office staff, and peer mentors to various locations throughout the state of Michigan in order to educate patients. Along with the programs listed on this slide, we've started what we call a hepatology boot camp, where we host referring provider teams to our hospital to shadow our providers for part of a day. I think they're usually here for, I believe, about half of a day, and they meet with various physicians and some of our hepatology staff. We do something similar with our kidney program on a more informal basis. Our kidney referring physician office staff can visit our hospital to observe how our clinical operations run and ask questions to our physicians and staff. We've also recently just developed or finalized a new mobile app, which is pretty exciting for our kidney patients that will provide important information to patients and families. This app, which is going to be downloaded on either an iPhone or Android phone, provides information on topics such as living donation, medication, and insurance coverage. We're also in the process of publishing 2 books. One is a book sharing adult kidney disease patient stories and their experience with transplantation and dialysis. And we are also working on publishing a children's book about transplant with 2 of our pediatric social workers. Wolverines for Life is also another collaborative effort between the University of Michigan, community, the American Red Cross, BMH, Gift of Life Michigan, and Eversight. It includes members such as students, athletes, alumni, staff, faculty, and campus and hospital leadership. The goal of the collaborative is to increase awareness of organ donation. Some of the events that we've held are things such as blood battles, an annual Be a Hero at the Big House, which is our largest blood drive at the Michigan football stadium, and other events include ice cream socials and other various events aimed at signing up donors on the registry. We have also opened 5 kidney outreach clinics throughout the state of Michigan. And these clinics are intended to provide a closer geographic clinic location for patients who live a long distance from Ann Arbor, which is where our hospital is, which is the green star on this slide. We provide both new patient evaluations at these clinics and annual visits before transplant at our outreach locations. And approximately a year ago, we also started offering post-transplant clinic visits at some of these outreach locations. Outreach clinics are staffed by a U of M nephrologist, a surgeon, social worker, nurse coordinator, medical assistant, a clerical person, and also a financial coordinator. Our liver program also has 2 outreach clinics. Their model is a little bit different. Our hepatology program has developed physician service agreements with 2 health systems that Michigan Medicine has recently developed affiliation agreements with. So unlike the kidney efforts where we see our own Michigan Medicine patients and send a full evaluation team, our hepatologists will travel to these 2 health systems to see their patients and serve as more of a consultative service to their GI doctors. And I think you're up, Jennifer.
All right. Thanks, everybody. I appreciate your joining in, and like I just did, hope that you're going to step away with a lot of really incredible, cool ideas. Let's see.
Corey, I'm not seeing my slides advance. There we go. All right. I also wanted to add in and appreciate thanks to the Alliance. They recently showcased in an email the upcoming Transplant Quality Institute, and I just wanted to kind of highlight the dates that it's going to occur and that it's joining the primer this year. The primer, I know many of you know, had to cease, and they're going to tag on an extra session in advance of the TQI. And abstracts you probably saw are due on March 31st. So what I'd like to cover, I think a lot of it is going to feel slightly redundant to Helen, and I'll avoid those areas and go into others in a little more depth. But I did want to highlight our own marketing team, how we're structured, what their individual roles are, sort of highlight some of those traditional methods we use in outreach, and then newer strategies that we've really feel have been successful for us, particularly with new technology. I was going to warn you a bit about some of the pitfalls when your outreach and marketing is successful, and pitfalls to avoid. And then again, like Helen just did for all of us, give you some, I think, pretty cool ideas. So there's some things about our transplant center that make the work of our outreach team so critical. It's like a lot of you listening in, we're in a highly competitive environment. If you were to Google map the address of my transplant center, Google Earth it, what you would see is that within about a concentric 2-mile circle, there are 3 kidney transplant programs, 2 liver programs. And in just our donor service area, we have about 5 kidney transplant programs. So I think that's important to know when you are reflecting on the marketing support that we've created internal. So this is my marketing team. I'm missing a couple in this picture, but they are absolutely unbelievable component of our program, as important as any member of the clinical team. We have 2 liaisons, and these aren't their exact titles, but 2 liaisons, 1 patient navigator, a director of the program, 1 staff member that focuses on communications and written materials, and then a volunteer ambassador. And to go over their roles a little more in depth, the liaisons are indeed liaisoning. Their job is to be on the road a lot more than they're here in the office. They're, I say, shaking hands and kissing babies, visiting those doctors' offices, cultivating relationships, and really out in the field at all times. The patient navigator is a little like the role Helen highlighted, where they had hired a social worker to go out and work at the bedside of the patient in dialysis units. We have 1 liaison that really focuses and visits both staff and patients. And then we have another really who navigates patients on our wait list with constant phone calls, updates, and love. And so for our kidney patients on the waiting list and our liver patients on the waiting list, that patient navigation is happening always behind the scenes. Our director is very strategic in her orientation. She's really looking at getting her foot in the door, looking for CME opportunities, looking for partnering opportunities, and higher level communications on relationships. I'll show you some of the work that she's doing momentarily. Our communications specialist, Shayna Puente, is the person who creates and really drives our social media campaigns, our social media websites, and produces a tremendous volume of patient and referring provider and living donor guides, written materials, audio materials, web materials, etc. And our volunteer ambassador, who is the woman everyone sort of focused around with the rose on her lapel, is a lung recipient who was transplanted 7 years ago and is just a pure ray of energy and joy. She rounds on our staff and our patients and our physicians with being empowered that all 3 are equally important in her role as a volunteer ambassador. I would love to say that we are just like University of Michigan's mentoring program, but we are certainly not as mature as that, but I'm really looking forward to stealing all those ideas. So that's our core marketing team. This group, they sit in an office just a couple doors down from me, but I would say that we extend marketing. Our coordinators are engaged, dietitians, pharmacists, physicians, obviously myself. You are not allowed to say no at University Transplant Center when you're asked to help in an outreach, education, or marketing opportunity. So focusing more on kind of that traditional outreach, one of the things I've really relayed with my director of marketing, Regina Delgado, is that I want their outreach effort to roughly be equivalent. It's an equation. The outreach effort equals referral loyalty times referral potential. So we try to look at referring physician groups in 4 tiers. A Tier 1 physician has a high referral loyalty. They love our transplant center. We see that we get most of their patients, and they have high referral potential. And that may be a group is a Tier 1 practice, or a physician within a group is a Tier 1, but their Tier 1s are our most important target for marketing and outreach. High loyalty to our transplant center, refer a lot of patients, and they have the capacity to refer a lot of patients. A Tier 2 is a physician who's loyal to our program, but they may have a medium to low referral potential. And then it goes all the way down to Tier 4, which you can see there, which is a low loyalty and low potential. And so again, if the outreach effort equals those 2 factors times each other, that roughly gives us an idea of how much energy and how to divide this group's activities. So some traditional outreach efforts, and again, the total effort varies per group, is a real focus on proactive communication. I always kind of tease my surgeons and doctors. Every once in a while, one of them will say, like, well, I want a billboard. Why can't we have some billboards? And I'll tell them roughly the cost of a billboard campaign, and I'll say, for that $175,000 6-month billboard campaign, you could just make 6 phone calls, and you would get me more return on investment. We should hardwire in our program 6 phone call systems. Call when a patient's referred, make a call back to the office to let them know you got the referral. This isn't necessarily a physician, but our transplant center needs to have a 6 phone contact. After their evaluation, at the time of their listing decision, at transplant, at their discharge, and at their 3-month mark, just to hand off and communicate. I would rather hear referring physicians say, you guys call me so much it drives me crazy, than a referring physician say, I never hear from you guys. So we really try to hardwire 6 phone calls, 6 phone calls. Obviously there are calls that need to happen at other times, and for some of our referring doctors they prefer a text, but really getting the entire program, physicians, staff, marketing, really aligned that is a key traditional never let it die marketing strategy. We round and identify issues. I know a lot of people in hospital work immediately begin to think rounding is what you do on patients, but we round at multiple levels. We round on our patients, our volunteer ambassador does, and they proactively, what could we do better, what went well. We round, we consider what they do, the liaisons do in the referring doctors' offices with both the physicians and the staff rounding. Just like you've been taught to round at the patient's bedside, what could we do better? Do you need anything from us? And we round on caregivers. What could we do better for you so you can support your loved one through a transplant? How can our educational materials be better? What would have helped you through this all? So our marketing team collates and tracks this rounding at all of these levels. So we are churning that information out and using it in our endeavors. And I won't go into role-specific education, but we do offer a lot of outreach to specific education. If our marketing staff discovers in a doctor's office they're really struggling with post-transplant patient medication issues, stable long-term post-kidney patients say that they're predominantly managing from a variety of transplant centers, we will have our pharmacists pharmacist out in that setting to do education. We get asked a lot about specialty programs and funding, so we'll bring social work and our financial coordinators out. I've been asked to come out and explain allocation and deaths on the waiting list and how to interpret the SRTR. So again, our marketing team is just grooming for those opportunities and trying to put experts in those offices to do education at a multitude of levels in our partners' offices. And of course, like Helen showcased, we do pre and post outreach clinics as well, and I'll talk some touch points on those in a little bit. So I like to kind of say that traditional outreach is really critical, but you have to have a good foundation for it. So for instance, when I say there's a Tier 3 referral, which is a doctor who's not loyal to us, we don't often see referrals from that doctor, and all of a sudden we get a referral, we need to do something differently at our transplant center for that doctor. So we have these doctors, we kind of call them like the red phone. Oh my gosh, he never refers to us, he loves the other guys. So what do we do differently when we do identify we have a referral from that patient? Well, we try to capitalize on a lot of those planned visits. I said we, and as an example over on the right you see for a Tier 1 doctor, very loyal, sends us a lot of patients. Our goal is monthly visits. And in 12 visits a year, we like for at least 2 of those to be with or include physicians, at least 2 of those visits to be with or include nurses. And if there is a problem with one of their patients or there's another problem, we like to go ahead and slide in a visit and really give our Tier 1 doctors concierge high-level service. Tier 2s, we like to do 6 visits a year. And Tier 3s or 4s are quarterly or less. So when I say things like a Tier 3 visit happens, what else can we do? That's our one foot in the door to try to turn that referring doctor's office onto my transplant center, like holy cow, they have great communication and outreach. So we go to those visits with, if we get a Tier 3 referral, instead of the next quarterly visit, we get on the road. We bring lists of our patients in case we have any other patients. We can give them status updates. We'll hand deliver a discharge packet like University of Michigan does. We take photographs and have our patients sign thank you cards to the referring doctor. Thank you for helping save my life. We'll hand deliver those, particularly if it's an unexpected Tier 3 referral. We like everybody in sales. We give food and try to give giveaways. And anytime we have new information, like I'll show you some samples of our printed material, we like to walk in the door with something to give them. And I did sort of showcase, if I think you can see it if I get my pointer right, over here in small font there, you can see that we produce a monthly marketing report to share among our entire institution and transplant center, so we sort of know where the marketing team is going next and be prepared for, if we know the marketing team has planned visits in the next 2 weeks, we go ahead and get the discharge packets to them instead of in the mail to the referring doctor or the thank you card. So, and I was going to show a couple of examples of when those doctors' offices, when we're rounding on those referring doctors' offices and they are mentioning confusions and problems they're having or their patients are having, this is where that sort of communications expert we have comes into play. So these are sort of some suggestions. They wanted a better referral form, and on the back of the referral form is just this simplified process. There's only 3 steps to refer a patient to us, and here's how you do it. And that really stemmed from direct feedback from a referring liver doctor's office. And then this next one is just a little information pad. They can peel that little sticker off in the middle and stick it on their refrigerator, and it educates a patient as to what their prescription labels mean. And these are things that, putting those referring doctors' ideas into action and then bringing them back into their office has been really a nice way to tie that circle and connect the loop. So rest of traditional marketing and outreach are those same things. We're doing promoting at CME events, promoting our own transplant center. Here we are at a liver disease event. We do all the blue and green and all the events we can do. We have a website. These are metrics that we track and report for visits to our websites and who's doing those visits and our success in those visits. We have done a lot of market research, and we see that patients are Googling our doctors, and they want information on our doctors. So we are about to publish for all of our doctors. We've stolen this idea probably from some of you on the phone. Instead of just a dry bio, we're doing a video bio, so the patients get a sense of the doctor's personality and compassion. And market literature shows that that is a highly successful route to take. We do a tremendous number of community education at almost every level: dietitians, social workers, nurses, laboratory staff can even come in if they're interested in HLA events. We participate in every local event that we can in mass. Not as mature. I love the hepatology boot camp idea we just heard about, but we do allow employees of dialysis units and referring GI and pulmonary offices to come observe a transplant. Certainly visit the center and provide a half-day orientation and training for anybody who's interested in that. These are our outreach locations. Texas, that's a little, if any of you listening in are for Texas, you'll appreciate this. One of our outreach clinics is a 10-hour drive away. The other one a 5-hour drive, 3 hours, and then some a little closer. In any one location, we may have pediatric liver 1 month, pediatric kidney, adult lung, adult kidney. So we have multiple outreach in multiple locations. We're adding telemedicine to these locations so that we can do between visit monitoring, particularly for patients that are high on the waiting list or early in that first year post-transplant. A little caution about outreach clinics. If you don't really showcase you're there, it's not really a marketing and outreach ploy. It may help improve your outcomes and your patient compliance, but we really try to push our doctors to highlight in their notes that I am writing you today, I'm seeing your patient in the El Paso Outreach Clinic. And our marketing team and our clinical team promote our presence before and after, and also during. We'll invite referring doctors' offices into outreach for lunch with us, or to maybe mutually see a patient or have a little mini selection committee afterwards. But I think if you do have outreach clinics, promoting them is often low-hanging fruit, and centers aren't doing that as well as they could. For new outreach strategies, I'm sure you all have social media pages, but I would encourage you, if you're on your cell phones now, and you shouldn't be, but follow our Transplant social media page, Facebook page, University Transplant Center. Followers have a marketing value. I think any company knows that. So a real focus of your social media page should be to grow your followers. We've discovered kind of 3 ways to grow our followers, and this was a post just from a couple of days ago. We call it our Faces of Transplant program. Our volunteer ambassador travel around the hospital. They visit new transplant patients in the clinic, and any patient willing to have their picture taken and tell a little story, like if any of you follow Humans of New York's web blog or page, you'll know it's just a 1 or 2 paragraph, sometimes just a 1 sentence, and this really lovely picture of just a person who's a regular Joe. And we have found those are incredible vehicles. We are reaching 54,000 people a month through it, and the more patient stories we put up, the higher our views go. You can use your Facebook and social media Instagram pages to highlight staff and referring doctors from their offices. Do you enjoy working with transplant patients? How do you feel with one of your patients get transplanted? They tend to share it with their friends and their own staff, and then if they do that, that means they're now following your page, and they're constantly seeing these wonderful stories that even my CEO will say, oh my gosh, I just read this story and it touched my heart. So those Faces of Transplant, marketing your miracles, is really successful. We also do a lot of highlighting our community leaders. and our nonprofit partners in town on our Facebook page. Another new marketing outreach strategy, and some of you may be trying this, but is something called a consumer reach campaign. And the CRM campaign, consumer reach marketing, this is direct marketing to patients and caregivers who are typing keywords into Google and Facebook and Instagram. So if somebody posts on their personal page, "Dad needs a liver transplant," or somebody Googles pediatric liver transplant, they will get a soft ad from my transplant center. I wouldn't be surprised if I see there's 70 people listening. Some of you have not gotten soft ads from my transplant center or other transplant centers in the country, because that's what these consumer reach campaigns do. And I'll show you a little bit, but you get these really excellent metrics, and I don't know how well you can see them, but one CRM campaign for our liver program generated 146 leads. And I'll go through and showcase what those leads sort of mean in a moment. But they show you what weeks the leads were successful, and we are changing the ads that we're pushing out to people searching so we can measure what ads were successful. And we can also kind of see, is it gastroenterologist clicking and looking for information, or is it actually patients and caregivers doing so? Excuse me. So this is to date our CRM activity. This is just for liver. We got basically referrals, 4 for pediatric liver, 32 for advanced liver disease, 54 for liver transplant, and 40 for living liver donation. Below are examples of the soft ads, they call them. You customize these ads to promote your transplant center based on key search words. We've tied that into a program called Tea Leaves, and I'm not trying to promote any particular product, but Tea Leaves is a system that ties our activity and connection to doctors, and when we go visit dialysis units, doctors' offices, or have a contact with a specific doctor, it will tie that activity to actual patient claims. So we can then see how many of that doctor's patients are getting lab work, bronchoscopies, CT scans, transplantation, hip surgeries at our hospital. And then we can also look at referring activity and use that in outreach. So we can go back to referring doctors and say, we can see you're using our facility for all of these things. The other nice thing about these systems are we can see where else physicians are sending patients. So not just for our transplant programs, but for our liver tumor center, our pulmonary hypertension, interventional pulmonary program, cystic fibrosis, we can see claims data that show us where our referring doctors are sending their patients. And I know there's some granularity with data you can pull from UNOS, but this is more real-time data. So if we do a CME lecture and Dr. Bowling attended that lecture, we can look the very next month by claims activity to see if we saw any corresponding increase in activity. So I'll move over to whining a little bit and talking a little bit about pitfalls and things, I think, not only thinking about those as types of strategies for marketing and outreach, but things to be on the lookout for. If I sent my team out to do tremendous promotion of my pediatric liver program, we have to be cautious because we're not centers of excellence for several payers. So if you know that your own SRTR data is dropping, it's going to jeopardize your centers of excellence designations. That's a time to be cautious about heavy marketing unless you are providing information on specifically what that office needs to do to navigate limitations on centers of excellence. I always say target your markets in an informed manner, and that's particularly for telemedicine and outreach and maybe for CME activity. You can ask UNOS for a custom data report for patients by zip code on the waiting list, by zip code at any transplant center and patients transplanted. You can also ask in that report that that be generated by payer type. They won't tell you specifically this person has Cigna Healthcare, but you'll see, is this a heavy Medicaid, Medicare, managed care? So if you potentially are looking at an outreach market, you may see that the surrounding zip codes have very few patients on the waiting list, and of all those patients on the waiting list, they're a heavy publicly funded population versus another market that has more patients on the waiting list that's heavier managed care. So if you need resources to go start an outreach clinic, it's a real helpful tool to be able to say to senior leadership, based on the payer mix and the volume of patients, we have the potential to get 22 more transplants from being in this area and promoting it. And of those 22 transplants, 19 appear to have been funded by privately as opposed to publicly. A couple of other pitfalls I would say is if you're successful, can you manage the volume? We got 146 referrals from Transplant when we launched CRM, and that was into a liver transplant program. That made it the single largest referring physician in our market, self-referrals. Well, self-referrals are a little more challenging because you then have to backtrack who's their doctor and how do you get the records, and it takes you a little bit longer. So our CRM campaign was quite successful, but we really didn't think about the impact on early evaluation and intake specialists. And then does the marketing and the clinical team stay really conjoined and communicate with each other? When we launched CRM, our clinical team wasn't quite aware of what it would mean, but we wanted to try to get those patients from getting our information on the internet to getting a phone call to getting an appointment really quickly. So I would just say those are pitfalls that really innovative marketing strategies, if you don't pull in the clinical team to both be prepared for the volume and simply be in the loop on what's happening, could really get you in trouble. And I would say each one of these things is something University Transplant Center learned the hard way. And then I'll just another shameless plug for the other markets. The other markets, this is highlights of patient feedbacks on our social media when patients post something really wonderful, a doctor's name or a staff name or just how great our transplant center was. That's something we're constantly communicating out internally to our OR, to our ER, to our GI lab, our IR lab, all those lab, just regular lab, HLA, all those places that transplant centers drive their own counterparts nuts. You know, they get frustrated by the urgency of what we do, the unpredictability of what we do, the complexity of our patients. But boy, they're just as touched by the miracles of transplantation as our own staff are. So I think when you have a marketing strategy, developing an internal marketing plan to make sure you're sharing your stories and you're getting feedback to the people that are helping you save these lives is invaluable as the marketing efforts you put forth in the referring doctor's office. And another market, if you look on the right of the slide, this is a flyer we sent to Interlink. Interlink celebrated their 20th anniversary, and we produced this little thank you, and we told one of our patients' stories with this lovely picture of her in front of the Texas Bluebonnets, and we got a letter back from the CEO of Interlink saying it was the most touching thing that they had, and they had sent it to every single employee at Interlink and had just unbelievable feedback. So after we did that with Interlink, and that's really our managed care partners kind of keeping us in the loop on some big momentous things. If insurance companies merge or they announce a new product line, we try to send them a little congratulation and a personal touch. We also send insurance case managers those photographs that Helen talked about and those thank you cards. We try to keep them and being recognized by their own patients for the work that they do. So I'll sort of wrap it up with I mentioned what a competitive environment my own transplant center was in, and we've been really fortunate to have gone through this long stretch of really excellent SRTR outcomes, low transplant rates. We've been really blessed, that those numbers reflect our efforts, and but no matter how good our outcomes have been and how much bragging we've done there in the community, those outcomes really haven't swayed referring doctors. What has swayed referring doctors is their patients are happy and they walk back in the office loving this transplant center. And so to that end, I just want to show you, this is my transplant center inpatient and outpatient, the NRC picker measuring our patient satisfaction. We're in the top 5%, and all of that rounding we're doing, how could we be better, how could we be better? And if a patient has a big complaint, we are the first ones telling the referring doctor about that complaint. And so I think if you can keep your staff passionate, having a good time, loving what they do, sharing those patient stories, letting them celebrate and do these events, of course your staff is feeling happier, they're loving on their patients. But what I tell everyone when they're hired here, I don't care what your job is, you market this program every time you pick up the phone, every time you file something, every time you're asked to retrieve a record, you're marketing this program. So we try to pull everyone in to work that way. So I'm going to turn it over. I think that leaves us with some time for questions. And I think both Helen and Helen's got her outreach team on the phone too to help with any questions that you might have.
Thank you very much, Jennifer, and thank you very much, ladies, for both such insightful presentations. Before I turn it back to Melinda for questions, just as a reminder for everyone, if you do have questions for our presenters, please submit them using the chat feature in the bottom left-hand corner of the screen. And while we're waiting on some of those questions to roll in, I'd also like to take this opportunity to remind you that the Alliance Transplant Resource Guide and Tools is one of our valuable signature offerings. It's a roadmap for developing and sustaining some high-quality, patient-centered, excellent strategies in donation and transplantation. So it offers strategies and change concepts, actions, and a lot of great supporting resources that enhance transplant program infrastructure and operations. So that's a completely free resource that's available to you at organdonationalliance.org/resources as well. Now, during the Q&A time, I will have this poll up. For those of you who are listening in a group, if you'll please complete this poll and let us know how many people were listening in your group, that would be very helpful for us. So at this point, I will turn it back to Melinda to moderate.
Thanks so much, Helen and Jennifer. I was feverishly writing down notes during your entire presentation because lots of good ideas. I think we have a lot of questions to start off. It seems like a lot of people want to hear more about tea leaves and maybe a little bit more detail about what that is and maybe what it costs even. If you could just expand on that, Jennifer, that's one of our first questions.
Sure. Thanks for that question. Again, tea leaves is simply the product my hospital happens to use. It's not a product where I think there's a multitude of products. What it does is it sits between all of your people out doing liaisoning are entering information. What physicians were at dinner? What physicians did you go visit? Who attended the CME event? Who did you have an interaction with? And so all of the liaisons are entering all of this information. There is a bank of claims data available to a large data repository. We have our own claims data within our hospital. So that physician activity ties to claims data, meaning billable patient activity at my own facility. So I can look at a referring GI doctor that we visited and say, how many colonoscopies did he perform at my hospital? How many CAT scans did he order? How many admissions occurred at my hospital? But through that data repository of claims data, we can also see, we can't see the patients, but we can see the volume of colonoscopies, CAT scans, and admissions he's doing at our competing facilities 4 hours away. So we're able to see where they're referring their patients doing procedures. So I can walk into a GI's office and say, oh, we're so excited we see that you did 245 colonoscopies and ordered CAT scans at our facility. Is there anything I can do to help you be in touch with those groups performing that for you? I hope that answered your question. And as far as costs for tea leaves, I'm not sure on tea leaves because tea leaves is institutional wide and Transplant's able to use it. We pay a separate cost for the CRM campaign though.
Great. Another question is asking Helen or Jennifer to speak to, do you consider collaboration with your OPO in encouraging organ donation part of your outreach efforts? And if so, how do you accomplish that?
Are you there, Stacy?
Yes.
Oh, I thought Stacy was, okay. Do you want to talk a little bit about the Wolverines for Life collaboration?
Yes. Sure. I'm Stacy Brand. I'm the outreach manager that works with Helen. So I would say the Wolverines for Life initiative started, it's been about almost 8 years now since the program started. And it's a way for not only the Transplant Center to promote organ donation, but to partner with the entire university campus, which includes students, faculty, staff, alumni, and we have formed subsets within the university. So there are student groups that have formed from the medical school, from the nursing school, so different subgroups that can promote organ donation and blood donation. And so we've also partnered with Gift of Life Michigan, which is our OPO. We've partnered with Eversight, which is the Michigan Eye Bank. We've partnered with Be the Match and the American Red Cross. So it's a very large initiative to be able to partner all together and to be able to offer a lot more opportunity across the university campus, but also across the state.
Great. Another question. I know I'll fully admit, Jennifer, when I was watching your slide, I was extremely envious of your outreach team. I'm curious. I'd say some people are sitting here thinking, how do you get your enterprise leadership on board to create such a robust team? Because I think most of us are probably working with 1 and 2 folks in terms of those that are dedicated within Transplant. So if you could speak to that just a little bit.
Well, I think every single thing in Transplant, and you'll all hate this answer, data is the key. So my communications specialist can specifically cull data from Facebook, individual patients that have gone on to be transplanted here. So her position pays for itself. My patient navigators, those are focused more on pre-transplant education, bedside visits, chairside visits at dialysis. Those positions have some component of them that are cost reportable, but we can track patient referrals to them. So every member of my outreach team has a return on investment associated with them. So we've really been able to capitalize on really excellent data collection that they do and showcase why we need to increase and expand.
Great. We have another question that came in that specifically wanted to know, what CRM provider do you use to track referring doctors?
The consumer reach management tool our hospital happened to use was a product called eVariant, and that I think that question combined the 2 products. Consumer reach really is consumer reach is really working to attach itself to somebody Googling. So if a referring doctor happens to Google liver transplant or pediatric liver transplant or liver cancer, they'll get a soft ad from my transplant center that's specific to their key words, but it's tea leaves. So eVariant is our consumer reach marketing it's kind of that same big brother software that Target and Walmart use to send you specific ads at your home. And then we use a product called Tea Leaves, and the Tea Leaves is where we track referring doctor activity plus our liaison activity.
Another question to ask if all of your outreach team is full-time.
They are now. The volunteer ambassador is a volunteer, and volunteers almost half-time and is grooming additional volunteers under her. And and one of our navigators, we just made a very successful business plan to show that if that navigator were to go full-time, that position would be substantially profitable for the Transplant Center. He went full-time less than a month ago, and it's already been profitable. His entire salary, we're above and beyond that in profit now.
Wow. Another question, are your physicians, this is for Jennifer or Helen, incentivized in any way to do outreach?
We do have, in Michigan, there isn't any incentive for the surgeons, but our nephrologists do have a monetary incentive based on how many outreach clinics they're covering. And it really depends on the travel distance to each site. It varies.
And our doctors, certainly for certain physicians that are doing outreach and education in the community, those can count towards their medical directorship hours if they happen to be in those positions. The hospital provides support in not only the staff that will coordinate the outreach activity, but in compensating their travel and expenses to do that activity. But we're very fortunate. I don't think I've ever had a doctor ask that question. Our doctors want to grow this transplant center. They want to be out there. They want to shake the hands and know that and work out there because it's growing our program.
I just wanted to add on to that, too, that I agree with Jennifer. I feel like our physicians are all on board. They want to go out there. They want to get to know the referring physicians. They want to be able to partner with them, and by having some FaceTime with them and being able to get their cell phone numbers and email addresses so that they can connect with them regularly, it just allows them to provide better patient care.
Looks like we're getting close on time, but there is another question about, do you have any suggestions in terms of organizations, conferences, meetings that you found beneficial in terms of getting specific outreach information where that subject has been explored that you would recommend to folks listening?
I think I've personally spoken really almost 3 times now on one of them. The most recent talks was Shamelessly Marketing Your Miracles, and it was a talk at the UNOS Transplant Management Forum. I think that, and Helen, I don't know if you have another one to add.
I don't. Stacy, do you have any other outreach activities or things that you've used?
Yeah, so I'm part of the American Association for Physician Liaisons. So though it's not necessarily transplant people, it's anyone who has a physician liaison type role within a health system. They've been a great resource over the years, and they have a lot of good information on their website and different conferences and education.
And one more I'll just throw in there is Donate Life America. I think OPOs live in the world of public awareness and hospital awareness. It's so critical to what they do that they have beat us by decades in outreach activities. And so you do find in the annual meeting at Donate Life America a tremendous amount of strategies on social media and educating referring physicians, et cetera. So and to the question earlier on how to collaborate with the OPOs to encourage donation, and did you consider that as part of your outreach? Certainly heavy content on that as well.
We have one more question. I think we have 1 minute left. Can you describe the process or method in which you identify larger regional partners or areas to target clinics or conducting outreach activities?
Well, I mentioned earlier, if we are looking for an area, I first start with a UNOS zip code analysis, and I ask for patients by organ listed or transplanted by zip code to include their payer type. And so I begin to narrow down the potential business in that area. Now, as far as identifying where to actually sublet space or have a clinic, that would be an entire webinar on the world's frustrations with subletting clinical space in outside of your hospital. So, but there is a hodgepodge of places. In some places we rent buildings 24/7. In some places we partner with our referring doctors, sublet their space, and are there for half days, and a multitude of different ways that we do that.
Many of our here too. Some of our clinics, we focused on our partners subleasing space from some of our higher referring physician groups, and recently the University of Michigan has developed some affiliations with 2 different health systems throughout Michigan, and we were already in those communities. So what we did is just move those subleases into the new affiliated space.
Great. Well, I think we're right at 4. So.
Right. Thank you very much, ladies. And we'd like to extend our thanks once again to Jennifer Milton and Helen Costis, as well as to Melinda Fox, for your time and for some fantastic presentations today. To all of our participants, we thank you for your time, and we wish you a wonderful rest of your week. Thank you very much, and take care.